Ladies and gentlemen, good morning. I'm thrilled to be able to present our long-term patency outcomes from randomized controlled trial patients who underwent open or endoscopic radial artery harvest at a period of greater than 5 years. Our previous trial results were presented last year in Prague and showed significant improvements in the endoscopic group for arm pain, cosmetics, and patient satisfaction, with a trend towards a decrease in wound infections in the endoscopic group. A subgroup of these patients were followed at 6 months and found to demonstrate equivalent patency rates between the two groups, and we hypothesized that this would carry over for the long-term period. Just some brief words about our technique. Our open technique is quite standard as conventionally described by Reyes et al. In 1995, and our endoscopic technique uses a non-sealed system, an adapted Karl Storz endovein kit with use of the harmonic shears and a single incision, similar to Connolly et al. From 2002. Of 119 initially randomized patients, we had 59 patients in the open group and 60 in the endoscopic group. At 5 years after we applied deaths, losses to follow-up, and refusal of consent, we had 30 in each group that underwent CT angiography and myocardial perfusion scanning, and 6 patients total that underwent symptom-driven angiography. This is our patency results summarized. We developed a 4-item patency scale to harmonize our CTA and perfusion scan results, whereby grade 1 is widely patent, grade 2A is a non-hemodynamically significant image artifact or possible stenosis. Grade 2B is quite similar, but an actually hemodynamically significant lesion. And grade 3 was a total occlusion. The results of the angiographic cases are on this slide as well. We see in summary that we get 87.5% patency in the open group and 91.2% in the endoscopic group without statistical significance between the two groups demonstrated. Our secondary outcome was quality of life, and we applied 2 self-reported questionnaires, the SF36, which in this we see all values above the baseline of 50 plus or minus 10 in all domains without significant difference between the two groups. And in the Seattle Angina questionnaire, we see a high level of functioning and quality of life with freedom of angina, and again, all quite high values in all domains, and a stability for the angina progression without statistical difference between the two groups. There are some limitations to the results that we have, namely that loss to follow-up, death, and refusal of consent accounted for 44.5% of the initial population enrolled in this trial, giving us the potential for a differential loss to follow-up bias, either strengthening or potentially weakening our results. Also, this trial was non-blinded, ultimately, because the results from the initial surgeries were available on our electronic medical record. And because of lower numbers, we weren't initially powered for a patency difference, and we may simply have just failed to detect a difference. Although in this we did see excellent patency in endoscopic group that's consistent with randomized trials looking at openly harvested radial arteries versus vein, etc. We have a high quality of life, level of functioning, and freedom from angina, and we can ultimately conclude that it's a durable, long-term patency result, no worse than conventional open harvest. Thank you.
We have a discussion at the end of the